Well, we're going to get started. Thank you very much, everyone, for joining us this morning for this very exciting program, Innovation in Cardiovascular Interventions, Recent Advances. I'm Raj Dave from Harrisburg, Pennsylvania, course director for the C3 program. And this is, okay. Dr. Artisani, can you hear me? Mia, can you hear me?
Yes, sounds great, Dr.
Can you hear me there, Raj?
Yes, I can hear you. Perfect.
I cannot hear you. So I'm going to start. Am I supposed to start my talk now?
Not yet. Just 2 seconds. I'll cue you in.
Okay. I cannot hear you. I hope you can hear me well. Just
I can hear you. Yeah, I think that audio with Dr. Artisani at his level. But anyway, Dr. Artisani is a program director for structural heart disease at Harrington University Hospital in Cleveland. He has done a lot of work on hemodynamics as a consideration for selection in TAVR. And Dr. Artisani will now start his first lecture, Hemodynamics as a Consideration for Device Selection in TAVR.
Okay, so thank you for the invitation, Raj. I'm sorry, I'm having some trouble with my sound here. I cannot hear you well, but I'm gonna give my talk, and meanwhile, I'm gonna try to fix the problem here. I appreciate the invitation and being here with this distinguished team of physicians, Dr. Stone and Dr. Agada. Is really a pleasure for me. I'm going to talk a little bit about the hemodynamic as a consideration for device selection for TAVR, which is a very important topic, even more so when you're dealing with this younger and lower risk patients. Okay, so let's start our conversation here, discussing a little bit of patient prosthesis mismatch, which is a concept that's been around for many years, but more recently we have started listening, hearing much more about patient prosthesis mismatch, which basically is happens when the EOA of a normally functioning prosthesis is too small in relation to the patient's body size, right? It's been very well documented in the surgical literature, and PPM actually is very frequent, right? And we know that when a patient has patient prosthesis mismatch, there is definitely a negative impact in terms of the regression of the LV hypertrophy, as well as in the long-term survival, right? And this risk is even more pronounced when we're dealing with patients with poor left ventricle function. So these folks, they do much worse when patient prosthesis mismatch is present. This graph, I think, has been seen by all of us many times, but this is just to emphasize the fact that when Evolut was compared with surgical valves, right, the results of EOA and mean gradients of Evolut compared with surgical valves was better, significantly better, and was sustained over time. This is a slide showing up to 24 months of follow-up. It is one of the, this is, I think, a very important study actually conducted by our colleagues across the street here in Cleveland. But basically, the message here is that it is important to give patients larger EOAs, and even more so when these patients are active. So the more active the patient's going to be, the better the hemodynamics of the valve you're putting in this patient needs to be. And this I think fits perfectly, and Hamo is going to talk about low risk patients on his talk, but it is important that we pay attention to, in the beginning of the utilization of this technology, right? we were focused on mortality, stroke, PVL, and conduction disturbances, which we still focus on, but also now we have to pay attention to the lifetime management of patients, and hemodynamics and patient prosthesis mismatch together with durability and life expectancy, as well as coronary access, which is another important topic. They are here. So we need to discuss the long-term plan of patients. It's not about being successful in the index procedure, but rather how this patient's going to live down the road, and what kind of quality of life we're providing to the patients. So this is of course a study that everybody knows, but it is important that we pay attention to the message here. And when you look at the S3 versus Evolut, right, in all of the quintiles of the analyst here measurements, we observed that the index DOA that Evolut delivers is definitely in all of the quintiles, similar valves, paying attention here. So similar valves, all of the quintiles, the EOAs provided or delivered by Evolut are better than the Sapien EOAs. And this is when you look at the DVIs consistently, even in the smaller annuli, you can see that Evolut delivers DVIs which are above 0.6 and significantly better than Sapien. This might have a long-term impact. We don't know completely yet what's going to be the long-term impact of that, but we have some data that I'm going to share with you. And patient prosthesis mismatch is important, that we realize that that does not happen only with surgical valves. It does happen with TAVR valves. So it is important that we understand that when we're going to pick a valve and select a valve, it's not any valve. So that we have to understand that patient prosthesis mismatch exists even in the TAVR population. So we have to pay attention to that. And this is important, and Howard Herman showed this very nicely on this study, is that any patient prosthesis mismatch with TAVR patients was associated with increased mortality and also with increased heart failure hospitalizations. More recently, this data was presented on ACC, and this is data from the pivotal trial as well as the Surtavi trial, basically picking arbitrary numbers for DVI, which is less or equal 0.5 or greater than 0.5. When they divided these patients, either in the TAVR as well as in the SAVR population, there was actually an impact in mortality. So the folks who had DVIs that were less than 0.5, they did have higher rates of mortality down the road. So this was an interesting piece of data that was again pulled from the high risk trial, as a pivotal trial, as well as from the Surtavi trial. But this is something to pay attention to. So worse DVIs, these patients did worse down the road long term in terms of increased mortality. And when you look at the data, the DVIs that Evolut delivers are consistently greater than 0.5, right? So compared with Sapien, which are less than that. So as you can see here, we would be in green for Evolut and in red for the DVI for Sapien. Again, we need to understand what is going to be the clinical impact down the road. This is at least there is some the signs that the DVI of less than 0.5 is going to have a negative impact on these patients. This is an interesting bench testing conducted by Philippe Barrault, but basically the bottom line here is that they put in a model, like in a bench model, a Sapien valve as well as an Evolut valve. And then the main message of this study is that the hemodynamic performance of the Evolut was actually statistically better than the Sapien valve when it was measured either by echo as well as by catheter. The pressure recovery, which is a controversial topic also, but occurred with equivalent magnitude between the Evolut Pro and the Sapien 3 valve. And also, when we increase stroke volumes, there is the hemodynamic advantage of Evolut was more pronounced than Sapien. And this is when I actually saw this, it's a very important piece of data. Again, talking about the younger patients that are going to be more active. We're actually conducting a study here, which is going to compare these two valves in patients doing a stress MRI. And there's much more to come, but I think we're going to see very interesting data for these folks when we exert them. And this is what we have, basically what he demonstrated, that the Evolut Pro demonstrated a 29% lower catheter gradient and 17% Doppler gradient in normal flow conditions, and 34 and 21 lower when these patients were when this not this patient but the model was under stress and higher stroke volume. This is also an interesting piece of data. It's a pooled analysis of some hospitals here in the United States. But basically here, what they're showing in smaller annuli, when we compare SAPIEN 23 versus the Evolut 26 valve, we can see that consistently the mean gradients were lower for Evolut, and not only at post-procedure, but also long-term. At the 1-year echo, we can see that the mean gradients were lower. And when we look at the definition for structural valve deterioration, you can see that they happen much more often with the SAPIEN valve. 16% of the SAPIEN valves had SVD by 1 year, and no Medtronic valves or no Evolut valves had that. This is some data from the VIVID registry, also showing, of course, that smaller surgical valves are associated with higher mortality rates. That's not news for us, but what is important to pay attention to is that there was higher rates of re-intervention. This is for valve-in-valve, obviously, right? High rates of re-intervention when you're dealing with valves that we did valve-in-valve with the SAPIEN valve rather than the self-expandable valve. We know that the hemodynamics, and we presented this on TVT, the hemodynamics as a late-break clinical science, but the hemodynamics of Evolut when we do valve-in-valve is great. The fact that it's a supraannular device delivers better hemodynamics, and likely this might be one of the potential explanations for the fact that the balloon expandable valves required more re-interventions when you do valve-in-valve. Just going quickly here, in terms of the leaflet thickening and immobility, what is the impact that has on durability? And as we know, there are different definitions for structural valve deterioration here. But very quickly here, I wanted to just emphasize that when we're dealing here with, when we're comparing surgical valves versus TAVR Evolut valves, right? We can see that there was no difference here in HALT and RLM, but yes, numerically it was lower, or it were observed less with the TAVR valves, although there was no statistical difference. I apologize that I don't have the values here, I just have the standard deviations, but the bottom line of this slide is that even though you had some HALT, even when it's greater than 50%, the gradients, the mean gradients in the Evolut valve were basically unchanged despite of the fact that the HALT was observed. As you can see here, HALT was observed very rarely in these valves. Out of 2 years, 0.2% of the TAVI or TAVR valves, there was a clinical leaflet thrombosis observed. Whereas in the partner trial, the data out of 2 years, 2.6% of the TAVR valves, we observed some degree of clinical leaflet thrombosis. And in fact, when you pay attention to the data, you can see that down the road, there was at long-term follow-up, there was an increase in some events such as death and disabling stroke. It's hard to correlate them directly, but this data is there and we have to consider and think about it. And here you can see that the valve thrombosis out of 2 years was higher with TAVR valves compared with surgical valves in the partner study. Very quickly here now, I want to show a case in the end. Is this 5-year follow-up of the CHOICE study. As we know, was a randomized study for SAPIEN versus self-expandable valve. And this is just to show that the balloon expandable valve, the rates of structural valve deterioration were higher with the balloon expandable valves here. And also the rates of valve thrombosis were higher in this series. That might be a potential explanation for that, the so-called neosinus. Not gonna spend too much time on this. We also have some data. This is the longest data follow-up that we have from the advanced registry, just showing the consistent and sustained hemodynamics over time with Evolut valves. Similar data coming from the Italian core valve registry. and the Notion trial which demonstrated that this was a low risk randomized study from the Nordic region that basically demonstrated that there's at least no concern in terms of structural valve deterioration with TAVR valves. Rather, there was more structural valve deterioration with surgical valves in this trial. So this is an important piece of data. Let me move quickly here. In addition here, this is another important piece of data. The Dutch registry just showing here that structural valve deterioration was more often observed with balloon expandable valves compared with self-expandable valves here. Now I'm going to just move quickly because I think I'm running out of time here. Let me just show, I think there is an important case just to illustrate everything we talked about. This is a 74-year-old patient that we treated recently, 3-month history of dyspnea and NYHA class, functional class 2. She has a BSA of 1.8. And this lady was a very active lady until she started being symptomatic. This is the perimeter 65.7 and the error 3.22, wide sinus of Valsalva, STJ also wide. This is our coronary takeoff. I think the important decision making, good access here of this patient is that this is the error 322 and perimeter of 65.7. If we're going to put a sapien valve in this, something happened here, 1 second. So if we're going to put a sapien, I apologize, I'm having some technical problems here. If you're going to put a sapien valve on this patient, she would have gotten a 20 millimeter sapien valve, or she can get a 26 millimeter Evolut. When we look at the EOA that we're going to deliver with a 26 millimeter Evolut, which is around 1.9 versus a little bit above 1.2 with a sapien valve, that makes a difference in this very active patient. And in fact, when we put her on this graph, which shows patient prosthesis mismatch should be in red for sapien versus in green for Evolut, that's the point I'm trying to make, that we have to deliver the best valve for that specific patient because we know that impacts mortality. And the procedure is just not the point of the discussion here, but I think the point of the discussion when we have to select valves appropriately, even more so when we're dealing with low surgical risk patients, younger folks who are going to have a much more active lifestyle. This is important, and we have to we're going to have better understanding of the impact of these numbers of these EOAs and DVIs and mean gradients down the road, but already we have some understanding that might have a deleterious impact in patient outcomes down the road. So I appreciate your attention. Thanks, and I apologize for this technical difficulties that I've had here.
Thank you very much, Guillermo. That was a fantastic talk. First of all, I want to take a moment to welcome Dr. Greg Stone, who is the Director of Academic Affairs at Mount Sinai Health System and Course Director of TCT Congress, and my mentor, as well as Lifetime Career Achievement Award winner of C3 2020, which we are hoping to give him in 2021. And also Dr. Hemal Gada, who is the president of the Pinnacle Heart and Vascular Institute in Harrisburg at UPMC Health System, to be part of this webinar. So thank you very much, both of you, for joining us. I also want to welcome our 1,600 plus attendees who are watching us via non-Zoom medium across Asian continent. I know it's a late evening out there, but thanks for taking the time to be with us. And I also want to welcome our domestic audience here as well. So, Hemal, do you have any comments about Dr. Artisani? Any questions?
I think, yeah, I mean, the hemodynamics are relevant, right? I think that we just haven't studied them the way we should. So can you talk about that? I mean, like, hemodynamics, a mean gradient of 14 versus 7. Do you think clinically there's an impact there, and how should we study that moving forward?
Yeah, can you hear me well?
Yes,
now?
we can.
Yeah,
Yes, we
because
can.
I was having some trouble with. I'm not sure what happened on my. So that's very important, Hamel. I think there's much more for us to understand here, right? It's hard to what's going to be the impact of those numbers, right? The 7 versus 14 of mean gradient. I think it's a little unclear still. I think there is this data that came from ACC recently, and some surgical data suggesting that might have an impact down the road. And I'm very interested on how much of an impact the exertion is going to cause. That's why we're doing this study here with MRI. So we're doing stress MRI with patients with SAPIEN versus Evolut, right? To try to show, I think, a further advantage of the supraannular platform in these patients. In addition, well, one thing that I think it's also important is that just like the case that I showed, that the fact that the valve is self-expandable, the hemodynamics is better not only because it's supraannular, but because you can oversize more liberally, right? So I think this is also a very important point here, that these valves enable you to oversize more liberally, therefore deliver a bigger valve, and on top of that being supraannular. What kind of an impact that gradient of 7 versus 12 or 14 is going to have down the road? I don't think this is very clear now, Hamel. I think we still need to see what's going to happen down the road. I think there's some indication that might have a clinical impact, which is what matters in the end of the day. But I don't know yet. I don't think we have a solid answer for that. Do you have any takes on this, Hamel? Anything?
Fodder for further discussion. And I think that we need to do VO2 max moving forward in all of these types of studies. I think that the stress MRI study you're doing is very interesting. But I think that we just need to apply more hemodynamically relevant metrics to assess clinical outcomes moving forward.
Greg, do you have any comments? Okay, in that case, let's move along. Thank you very much. Great discussion. And I'd like to now have Dr. Hamel Gada from UPMC in Harrisburg to discuss low-risk patient population. And TAVR, what does current data tell us about device selection? Hamel.
Absolute pleasure to be here, Raj. Thanks for inviting me. Great to be on with Drs. Adesany and Stone as well. So what I'll do is just breeze past my disclosures here and just a brief introduction to my program here in Harrisburg, Pennsylvania. So as you can see, we've had a very rapid upslope in our TAVR volumes over time. So I joined the program back in calendar year 2015. We were integrally involved, just like Dr. Adesany was, in the SURTAVI trial. And really, after that, intermediate risk commercial came out, and then we started rolling the Medtronic low risk trial. And then, of course, the boom that we've seen last year, and then also this year as well. I mean, we picked up quite nicely after about April, when we had kind of been put on effective pause because of COVID. We've still picked up, after that. So Q4 of this year looks like our most, I would say, productive quarter as far as transcatheter aortic valve replacement is concerned. And we're probably going to be right around that number of 386 that we were last year with regards to our volumes. So what's facilitated this? Well, when I left fellowship at Columbia under the tutelage of Dr. Stone in 2014, this is kind of where we were. And, it was irresponsible and reckless to consider transcatheter aortic valve replacement in low-risk patients. And so the clinical use was refined to the right side of that spectrum, where you had high and extreme risk folks, but the research was ongoing. And the two pivotal trials that Dr. Adesany had touched on, the PARTNER 3 trial and the Medtronic low-risk trial, led to an FDA-approved indication for commercial low-risk transcatheter aortic valve replacement. And so now, when we look at 2020, all of a sudden, the current TAVR clinical and research use encompasses the entire spectrum of surgical aortic valve replacement, which is nothing less than a revolution over a very short period of time. But with that comes a lot of responsibility. We really have to think about these patients more in depth. And so we have to focus on the hemodynamics. So I'm going to supplement a lot of what Dr. Adesany just spoke about. The durability matters. Avoiding morbidity like paravalvular leak and pacemakers also matters. And then thinking about lifetime management. What happens to these low-risk patients down the road? So I'm hoping to shed a little bit of insight with regards to device selection and also therapeutic selection, surgery versus transcatheter aortic valve replacement, which I think is a bigger, more interesting question in these low-risk patients. So let's just pause here with regards to how we assess these patients. This is right out of the valvular heart disease guidelines in 2014 that had a focused update in 2017. And when we think about low risk, we automatically jump to STS score. And that's fine, but that's not all of surgical risk. And so the STS predicted risk of mortality makes up that top row. Second row there is frailty indices. Third row is Morgan or major organ system compromised not to be improved postoperatively, like renal failure. Maybe you have bad pulmonary hypertension, bad pulmonary disease. You don't want to intubate the patient. Maybe transcatheter aortic valve replacement would be favored there. But the most interesting row is that last one, procedure-specific impediment. And this, I think, digs a little bit more at the hemodynamic argument that Dr. Adesanya was making earlier, and this whole concept of patient prosthesis mismatch. If my surgeon is sizing a patient for a 21 millimeter surgical prosthesis, and we know that we're going to be able to get in the 26 millimeter Evolut, is that patient really low surgical risk? Because there's a lot of data pointing us towards hemodynamics and deleterious outcomes with smaller valve sizes. And so this is out of the surgical literature. Let's just harken back to it. This is 60,000 patients in the STS database. And then we're looking at any degree of patient prosthesis mismatch. So not just the severe patient prosthesis mismatch, but any degree of patient prosthesis mismatch is going to decrease long-term survival and increase readmission rates for both heart failure and reoperation for aortic valve replacement. This is a meta-analysis encompassing over 133,000 patient years of data. Again, looking at patient prosthesis mismatch and linking that to all-cause and cardiac-related mortality, any form of patient prosthesis mismatch. Looking at structural valve degeneration, where historically that was just freedom from or getting a reoperative AVR over a period of time, the definitions have morphed a little bit more precisely, looking at gradients and levels of insufficiency now in addition to the reoperation. Point is that if you have patient prosthesis mismatch, your valve's going to degenerate much more rapidly than if you don't. And then what leads to this? Well, there are a variety of different factors that would lead to structural valve deterioration or degeneration. But one big one here is the size of less than or equal to 21. And so that's a key number when we think about surgical valves. Transcatheter valves may be a little bit interesting because there's a different number in mind, but 21 is kind of the number that I would use. And again, if your surgeon's saying 21 millimeter valve, like light bulbs should go off in your head, that's a bad thing for a patient. Do hemodynamics really matter? Dr. Adesanya showed this slide in a different form, so I'll just gloss over it. We're talking about 62,000 patients that Herman and colleagues analyzed in the TVT registry, predominantly balloon expandable patients. And when you have a severe degree of patient prosthesis mismatch, your mortality curve differs from the other population, not in years, within a year. And so that separation is quite palpable very early on. What predicts patient prosthesis mismatch? Well, this is the number I was talking about. So 23 millimeters, right? 23 millimeters gives you an odds ratio of greater than 2.5 for incurring patient prosthesis mismatch in this particular group of patients. So in transcatheter aortic valve replacement speak, we should really be focusing on 23 millimeter valves or below as kind of adjudicating whether or not we're thinking we're going to be giving our patient the benefit of transcatheter aortic valve replacement. If we've got one platform that sizes for a 23 and another platform that sizes for a 26 or 29, we should really be thinking about that 23 millimeter valve. Dr. Adesanya also talked about this, just glossing it over, but every single quintile that you would compare from an intraannular versus supraannular prosthesis, you're going to get a better effective orifice area index using the supraannular prosthesis. So with all of that, let's just transition to durability and what type of inklings we have in the surgical literature that we can apply to transcatheter aortic valve replacement. So first of all, should we expect SAVR and TAVR durability to differ? I think this is very interesting. TAVR leaflets are thinner to allow transcatheter device delivery. They experience higher stresses and strains, particularly in the presence of calcification and non-circular annuli, resulting in asymmetric stent frame deployment. The durability of TAVR might even be shorter if the prosthesis is underexpanded due to TAVR oversizing. The TAVR valve requires crimping or loading and may have more paravalvular leakage. And first generation TAVR valves did not have anti-calcification treatment. Underscoring here, data from computational tissue fatigue models suggest that even when a TAVR is properly deployed, durability is predicted to be about 7.8 years less than SAVR. So really bad things, but practically should we be concerned? And that's kind of what I want to transition to. So what is the surgical standard for bioprosthetic valve durability? I really don't have much to say about that. Why? Because despite rigorous guideline documents discussing a multiplicity of causes for structural valve deterioration, the surgical clinical standard for durability has been median time to reoperation with minimal event adjudication. More recently, there's been this trend to also incorporate echo measures of valve degeneration, which has been meaningful, but not systematically applied to new surgical valves. So the bottom line here is that an unknown number of patients with SVD of surgical valves will not present for reoperation. So our data is flawed. What we do know is that the younger the patient is when they do get a bioprosthetic AVR, that the durability tends to be more limited in those particular populations. There's a variety of different theoretical things we can kind of throw at that, but this has been shown time and time again in the surgical literature that if you get a bioprosthetic valve early on, your risk of degeneration is going to be higher than if you get it later. Freedom from structural valve deterioration in a Hancock porcine AVR showing exactly the same curve. Freedom from reoperation 10 years post-SAVR. Again, keep in mind that a lot of these patients are kind of lost to follow-up. If you look at the number at risk here versus the total number of patients and versus the follow-up years, you're going to find a lot of attrition in these analyses. And so the point here is, we don't know what we don't know. Again, looking 15 to 20 years, obviously numbers are more limited here. Again, showing that there's a lot of dropout, a lot of attrition. These people don't all live 15 or 20 years after the surgical aortic valve replacement. So do we actually understand SAVR durability, much less TAVR durability? Early surgical valve failure is a thing. We've seen this with the trifecta aortic valve, Medtronic Mosaic valve, MitraFlow valves, trifecta again. And then let's just shift to TAVR durability. So what do we know about TAVR durability then? Well, we can look at some data that's 5 to 8 years out. We've got case reports of 9+ years now, which look good, but again, small numbers in the large majority. What we do know is that when we look at self-expanding versus balloon expandable platforms, there does seem to be a difference there. And Guy pointed that out in the CHOICE randomized control trial. We've seen that in the NOTION trial, which is the longest term follow-up of low-risk patients that we have, that severe structural valve deterioration happens much more, it seems, with balloon expandable and intraannular surgical platforms than with the self-expanding supraannular prosthesis. Showing NOTION here out to 6 years now, you can see that moderate or severe hemodynamic structural valve deterioration is significantly different between the core valve prosthesis versus a surgical AVR that was used in NOTION. However, it is a very incomplete picture because we have not been doing TAVR in the lion's share of patients who are at low risk, who are younger. And what we know from the surgical data is that those patients are the ones that tend to have more limited durability. So more to come, but I think we can at least posit that with the data that we have currently, durability as it relates to a supraannular platform appears to be quite good. Well, what about morbidity in low-risk patients? Let's talk about that. Well, paravalvular leak, big issue. There have been a lot of technical innovations applied to transcatheter heart valve prostheses over the last few years that have pretty much eradicated severe paravalvular leak, and this goes for Evolut Pro as well. Then let's transition to PPM, or cute way of acronyming permanent pacemakers versus patient prosthesis mismatch. Well, permanent pacemakers appear to be a problem with the supraannular platform, and that's shown trial and trial again. But when you dig into the weeds, something really does pop out with regards to this. We do know that in PARTNER 3, it was a non-inferior rate of conduction disturbances, TAVR versus SAVR. When we dig into patient prosthesis mismatch and the whole question to Guy about a mean gradient of 14 versus 7 or 13 versus 8, it'll be interesting to see if that shows a clinical difference over time. What we do know about PARTNER 3 is that these 30-day outcomes, a mean gradient of 12.8, escalated up to 13.7 by the end of year 1. And then if you look at the hard outcomes as they relate to PARTNER 3, those curves start diverging or converging together from year 1 to year 2. And so what is going on with these gradients? And maybe in the smaller valve sizes, there is some sort of clinical impact, because this is the first clinical trial where TAVR was randomized to SAVR, and TAVR was inferior to SAVR with regards to hemodynamics. In addition to that, if you look at PARTNER 1, PARTNER 2, PARTNER 3, you see a steady escalation in mean gradient. And so across different platforms of SAPIEN. So is there a gradient problem, and how do we fix that? Is it something reasonable to fix? Whereas in the Medtronic low-risk trial, again, the supraannular prosthesis tends to have better hemodynamics than surgical AVR. This is a scatter plot, funnel plot of the Medtronic low risk trial, site by site, pacemaker rate on the y-axis here, number of subjects implanted on the x-axis here. You see a considerable amount of variability with regards to permanent pacemaker incidence. 17.4% is the mean number here. This is my site over here. We were the #1 enroller in the trial. We're out of the bounds of 2 confidence intervals. And that's independent of a whole host of different things. Inbound right bundles, inbound permanent pacemakers, inbound left bundles, pre or post dilation. If you look at all the bubble plots, they're basically the same patient. So the point is that implantation technique and the way you actually do these procedures probably matters. This is just an overview of what Medtronic is kind of rolling out as a commercial standard now, which is cusp overlap. It really is a view that is supposed to highlight the conduction system for you, so you implant the valve in a more reasonable, reflective way as it relates to the conduction system. What about coronary reaccess? So my good friend Gilbert Tang has done a lot of work in this. He actually presented a very nice analysis, or is going to be presenting it at TCT Connect. This is just the preliminary work that was done in this arena. Again, the concern here is you've got this core valve frame. How are you going to engage the coronaries? Well, it turns out that we can actually manipulate the platform prior to putting it in. That makes the coronary ostia a little bit easier to engage. A lot of that is understanding of how the valve is loaded and then what type of manipulations we actually have to make on the table in order to make sure that one of these commissures or stent posts is not directly in front of the ostia of one of the coronary arteries. And so when Gilbert started just kind of looking at the bench testing and how the C-tab, the commissural tab on the top of the valve, relates to the hat marker on the bottom of the valve, he found a 90-degree offset. And basically, the thought here is that you really want to avoid this particular circumstance, which is the incidence of severe overlap. And so when he looked to see where this hat marker was positioned and what happened to then subsequent attempts at coronary reaccess, meaning is that post in front of the coronaries, he found an anatomic difference. And the way we minimize that is by putting the hat marker in the outer curvature. So when we're coming across in an LAO view, we want that hat marker to be facing towards the outer curve. When we go to cusp overlap, we're actually going to have the hat marker in center front. And that is going to reduce the incidence of a commissural stent post being in front of the coronary arteries, facilitating not just coronary reaccess, but potentially basilica down the road if we're thinking about doing a tab and tab. Looking at the outcomes here, when you just create that hat marker on the outer curvature by shifting the flush ports away from you with the Evolut system, you reduce the incidence of this overlap. Again, showing just a case here where basically he's going along the outer curvature, trying to get that hat marker to kind of fit the outer curvature. This is in a cusp overlap view where the hat marker is in center front. Combining cusp overlap and commissural alignment, he's shown this very well. Basically, as you see the C-tab release, it's going to be kind of offset to the side of the screen here. And then again, comparing what you look like in a 3-cusp view versus a cusp overlap view, this is basically good commissural alignment, meaning that your commissure, your neocommissure is going to be offset from the ostia of the coronary arteries. So TAVR's true limits hasn't met the test with a variety of different factors. Mortality, it appears so. Hemodynamics, depending on the platform, I think the supraannular platform, definitely. Morbidity, we're getting there. Paravalvular leak reduction, pacemaker rate reduction. The quality of life, at least the short term, is very palpable as far as the difference is concerned. Longer term, we're going to need an assessment as far as what the effects of those hemodynamics are. Durability, we slowly are getting more data, and we will over time. Patients obviously accept it, and then cost effectiveness is a whole nother discussion with regards to TAVR versus SAVR. So like most things long-term with TAVR, we don't know more than we know. Hemodynamics should be important in defining short-term quality of life benefit and intermediate long-term hard outcomes. The last wave of research, the one that we just did, needs to follow through to draw any firm conclusions, the PARTNER 3 and the Evolut low-risk trials. Durability appears to be holding up for TAVR in the high-risk patients implanted years ago. The critical follow-up here will be in the low-risk patients. Mitigation of paravalvular leak and conduction disturbances has occurred through technological innovation and procedural nuance. And lifetime management issues merit further thought and innovation, and that will be the focus of the next wave of clinical research. So again, thanks for the opportunity to present today, and I'm happy to entertain any questions from the distinguished panelists.
Thank you very much, Hamel. Fantastic lecture. Dr. Tizani, Dr. Stone, any comments?
No, I think it was terrific talk. Can you guys hear me now okay?
Yes, we can hear you great. Yeah.
Beautiful, perfect. Hi, hey, great to see you, Amal. How are you?
Hey.
So let me ask your 2 specific questions for you. maybe I'll ask 3 questions. I know it's tough. So, are we through worrying about HALT, okay, and leaflet thrombosis issues? And where are we with chronic anticoagulation, or 3 to 6 months of anticoagulation, or just treating patients who present clinically versus patients who we find asymptomatic HALT on? What are your feelings?
Great question. And the reason why I didn't dig into that topic is because that would take like another hour to like talk about how confounded the literature is and how it doesn't translate the clinical outcome, and how any type of pharmacologic management steps that we make really doesn't do anything as far as the current data would show. So I'm just going to say, I don't know, Greg. It's impossible for me to assess that question given what the data is currently.
Great. Yeah, and I would agree. We certainly don't have clinical data right now to suggest we should be doing anything differently, and it occurs frequently. It occurs after surgical prostheses as well as after TAVR. It does seem if you find it, then anticoagulation will help resolve it. So it's probably usually thrombus, but its linkage with long-term outcomes is very unclear. So I would agree with you. How about treatment of bicuspid aortic stenosis? How confident are we in treating selected low or intermediate risk patients? These are pretty young patients, so you also have the durability issue as well.
Great question as well. So, I mean, obviously we now have at least one low risk registry for Medtronic that's come out, looks very good as far as outcomes are concerned, but are these surgical outcomes, right? And so there was no head-to-head, we don't have randomized control data, but I would think that the majority of bicuspids, if you thoroughly evaluate the anatomic milieu in which you're implanting the valve, that you're going to escape with a good outcome. And I think that is something that in our heart team discussions for intermediate and high risk patients, we have no qualms about it. When we're thinking about a low risk patient and we're thinking about potential durability, efficacy things that are longer term, then it does lean us more towards surgery. So I think we definitely need more data with regards to TAVR and bicuspid patients, because we just have a limited amount and we haven't followed them through for many years.
Right, and there are some concerns about greater stroke rates and greater
Sure.
paravalvular leak, especially in the heavily calcified bicuspids, et cetera. And last question, and sorry to be really hammering you here. What are some specific circumstances where you might consider a self-expanding valve versus a balloon expandable valve?
I think you've got kind of a bias to the panel here. I think that Guy and I would kind of give you answers that are probably dissimilar to other places. But I think that, I would say in some anatomies, a balloon expandable valve obviously is a great valve. And we're talking about severely angulated roots, heavily calcified leaflets where paravalvular leak would represent a residual concern. I think that some of the dynamics of the platform are going to put you in better stead to have a better result. Similarly, SAPIEN Ultra with its paravalvular leak reduction in the 23 and 26 millimeter valves now, I think that if you are dealing with those heavily calcified anatomies, then we'd probably go more towards that. But in the vast majority of our patients, I know Guy and I agree that we prefer the self-expanding supraannular prostheses specifically because we think we can get an excellent clinical outcome with regards to the hemodynamics and obviously get great PVL reduction, great pacemaker incidence reduction with the implant techniques that we use.
Great. What about the coronary reaccess, Hamel? That
yeah,
a big concern out there.
It takes training, right, Raj? And so basically, I think that the commissural alignment is a good step to do with every single Evolut that you implant. And then Medtronic does have a HeartRoid simulator that they can wheel out to pretty much any lab in the country to go over with the docs how to basically engage through that stent frame. The great thing about Evolut is that you can actually position the commissures differently. Whereas with SAPIEN, you can't do that. And so you may actually have a stent post or an edge of a diamond up against the ostia of the left main or the right coronary, not be able to do anything about it with a SAPIEN. But with an Evolut, I think you'll be able to do a lot more.
Just one comment, Hamel, here.
What do you think about, the coronary reaccess with the other self-expanding platforms, which are not available in the US, but maybe available in future, such as Portico,
Yep.
Also the Lotus?
Yep. So Lotus is another interesting one because you're talking about a frame height issue there. So when you deploy that valve, you're going to have a 19 millimeter frame height. If you're going for more of a shallower deployment to mitigate conduction risk, you really have to be knowledgeable about that coronary anatomy. Because the problem is that if that frame is up against, I know there are case reports of people going through that little stent frame and blowing up balloons and stuff like that. That's very hard to do. So I think Lotus, you have to be very cognizant of coronary heights. as far as Portico is concerned, as far as Accurate is concerned, or Accurate Neo or Accurate Neo 2, I think that there are some advantages there to coronary reaccess, but those valves offer different hemodynamic profiles, different physical properties that you really have to consider as well for other reasons. So we just can't focus just on coronary reaccess. We have to take each valve holistically with the benefits that they provide versus some of the challenges imposed down the road.
Just one comment here, Hamel, to Greg's question for you about the bicuspid, right? So what do you want, because there are bicuspids and bicuspids, right?
Yeah.
Sometimes what we have been doing here, I'd like to hear your perspective of this, is that sometimes you have those heavily calcified bicuspid valves with a heavily calcified rapid, that you know that the valve is not going to be, the expansion is going to be limited. And while we can get a very good, acute result, down the road to treat this patient, right, it's going to be a problem to get a good hemodynamics, et cetera, et cetera. So I would like you to comment about that. What is the rationale? How does the discussion happen with your surgeons? That's the question.
Yeah.
Question number two is, I think you made a very important point in terms of when you were discussing how we're going to treat these low risk patients or younger folks, right? What kind of surgical valve you're offering to this patient? What kind of procedure? Oh, we're going to enlarge the root versus I'm going to give this patient a evolute valve, a supraannular valve, right? And that the enlargement of the root is going to increase the surgical risk. How do you put this in perspective? How does this discussion of the heart team happens in your center?
It's complex and it's idiosyncratic. So there's no paint by numbers type of rule here. Everything is focused on the individual patient and all the unique clinical characteristics and anatomic characteristics they're bringing to the heart team. And so as far as surgical assessment is concerned of a bicuspid valve, do we have protruding LVOT calcium? Do we have a Sievers 2 bicuspid? I mean, those are extraordinarily difficult to manage with a transcatheter valve, I think. I think we'll probably shunt those over to surgery, even in intermediate risk patients. But to your point, we're going to be able to get a pretty good result with most Sievers 1 patients and with Sievers 0 patients as well with TAVR. So I agree with you. I think that we probably put those more into TAVR world. And then, with regards to the heart team assessment as a value as a whole in all of these patients, we have to compare what is going to happen in the OR to this patient. How long, how prolonged of a surgical approach is this going to be? Is this going to be a defined root enlargement where we're going to be taking a 19 millimeter and potentially putting in a 23 millimeter valve? Or is this going to be a 19 versus a 21? And I think those little idiosyncrasies need to be worked out routinely between the surgical team and the structural transcatheter team, if you will. And then we can, definitely get consensus on the vast majority of patients.
Thank you very much, Hamel and Gui, as well as Dr. Stone. We're now going to continue further with the program. We're going to switch gears a little bit. We're going to now talk about patients who are at high risk of bleeding and what are the new insights from Onyx 1 and other trials looking at antiplatelet drugs and PCI in these patients. Dr. Stone is going to do this presentation. I'm going to turn it over to Dr. Stone now.
Great. So I'll share my screen and let's see, I think it's that talk. There we go. All right. You should be seeing my screen.
We see great. Yeah.
Beautiful. Well, thanks, Raj, again, for asking me to give this talk. It's interesting. It's good to get back to coronary intervention. It's fascinating now where the time in seminars where coronary intervention, it was almost the afterthought after structural heart disease intervention. But I'm happy to talk about the high bleeding risk patient, and relevant to this talk, I have no financial disclosures. I was the chairman for the Onyx 1 and Onyx 1 Clear studies, but I was uncompensated. So when we talk about the outcomes of PCI with drug-eluting stents, it's really all about ischemia versus bleeding. When you consider what lesions to treat, whether the patient should even undergo intervention versus surgery versus medical therapy, what the duration of DAP should be, and other considerations. The ischemic events, myocardial infarction, stent thrombosis, and stroke, that can lead to marked disability or kill patients, but so can major bleeding. And that could be either access site or non-access site related, can involve intracranial bleeding, GI bleeding, and other sources as well. And every patient will have a unique balance. Some will be at greater risk of ischemic complications, other greater risk of bleeding complications. So in terms of DAP duration, there's actually been now more than 22 randomized trials of DAP duration in greater than 57,000 patients. It's pretty extraordinary. And you can see from the duration of these bars, everything as short as 1 month has been tested, and everything as long as 4 years has been tested, with a lot of intervening relative rates: 1 month versus 12 months, 3 months versus 12 months, 1 year versus 3 years, et cetera, et cetera. So there have been numerous meta-analyses that have been published on this, and this is one of the larger ones of 17 randomized trials and 47,000 patients, and they all basically show the same thing. And the bottom line is that the longer the duration of DAPT, the greater the protection from ischemic complications, particularly myocardial infarction and stent thrombosis. However, the longer the duration of DAPT, the greater the risk of minor and major bleeding. Now, if you look at overall, the question is, what net effect does longer DAPT have? And overall, there's been either trends towards increased overall mortality or neutral overall mortality. So from these types of analysis in a Bayesian framework, you can come up with what's called a rankogram of the likelihood that overall, what would be better? Short DAPT, that is less than or equal to 6 months, versus standard DAPT of a year, versus long DAPT of greater than 1 year. And you can see for myocardial infarction, the longer the DAPT, the better in preventing MIs. Same for definite stent thrombosis. But for major bleeding, the shorter the DAPT, the better, without any doubt. When you look at the overall effect on all-cause death and cardiac death, in general, shorter DAPT has a stronger relationship with freedom from mortality. We've actually looked at this more directly. We've published a lot of meta-analyses and direct trials on this. This one from Tullio Palmarini a few years ago in JACC. And the reason that bleeding is harmful is actually because it causes bleeding-related deaths. When you look at this trend towards increase in mortality, it doesn't affect non-bleeding related deaths. It directly affects bleeding-related deaths. So shorter DAPT is associated with a reduction in bleeding-related deaths. Now, when you talk about ischemia, we also know that the type of stent that you use is very, very important. So from some of these early meta-analyses, when we talk about longer DAPT reducing stent thrombosis, it depends on the type of stent. So this from Gennaro Giustino at Mount Sinai showed that in one of these earlier meta-analyses, there's a very important interaction wherein longer DAPT reduces stent thrombosis with first-generation drug-eluting stents, but not so much with second-generation drug-eluting stents. And in fact, this was also seen from the DAPT trial. If you look at the DAPT trial, which you remember was 12 months versus 30 months of DAPT, they had multiple different stent types, but they only had one second-generation stent, which was everolimus-eluting stents, and 4,700 randomized patients. And you could see here that, yes, longer-term DAPT was associated with less MI and less stent thrombosis, but the differences were not huge. It's like 0.4% and 1%. In contrast, major bleeding was almost doubled with longer DAPT, and the net effect was actually an increase in mortality. So we really have to be very careful to not cause bleeding in our patients. We have to use DAPT as long as necessary, but not longer. And that's a problem in the United States in particular, where we tend to use DAPT for a long time because the patient, seems to be doing well. They're not having a bleeding complication until they have a bleeding complication. So what is going to be the right duration? Well, you have to weigh these varying factors of ischemia versus bleeding. And this is from an article that we published. Many people have published this, looking at the relative risk factors. And people like to say that they're the same risk factors that predict bleeding, predict ischemia. But that's really not true. For example, acute coronary syndromes, stent type, and disease complexity primarily predict ischemic risk. In contrast, age, recent bleeding, baseline anemia, use of chronic oral anticoagulants primarily predict bleeding risk. So you have to weigh all of these, and this will relatively favor longer or shorter DAPT. Again, for ischemic risk, I think clinical presentation, that is whether the patient's got a troponin positive ACS, whether the patient's got complex lesions or multi-lesion intervention, and if you're not using an optimal stent type, those are important factors that really predict to increase ischemic risk. But what about bleeding? Well, the HBR, or high bleeding risk ARC group, got together and did a very, very careful analysis and really did a beautiful job pointing out the risk factors for high bleeding risk. And age is a unique one. Age greater than or equal to 75 years does not predict ischemic risk, but does predict bleeding risk importantly. Comorbidities, renal disease, liver disease, active cancer, lab findings, that baseline anemia, low platelet count, CNS disease, prior or recent stroke, intracranial hemorrhage, or a brain AV malformation, a history of bleeding diathesis, prior bleeding, or transfusions. And then there are iatrogenic causes such as use of oral anticoagulants, nonsteroidals, or planned surgery on DAPT, recent trauma, or recent surgery. And importantly, most of these patients have historically been excluded from clinical trials. So they came up with a risk score called the HBR bleeding risk score, and they broke this down into major and minor criteria, and I won't go through them in detail, but basically if you have one major or two minor criteria, that is HBR, that is high bleeding risk status, and that confers a major bleeding risk, that is BARC 3 or 5, of it greater than 4% at 1 year, or an intracranial hemorrhage risk of greater than 1% at 1 year. So this is definitely worth learning about and trying to apply to all your patients. Now, what about the interaction between the stent choice in high bleeding risk patients where you want to use a short DAPT duration? Well, this was really first studied with a very novel stent. And this stent was called the BioFreedom stent. It's still called the BioFreedom stent. And it's a polymer-free stent. And it's got this micro etched surface architecture, which can hold on to a very lipophilic drug like Biolimus A9 and deliver it to the site of the lesion before it elutes markedly from the stent. And they chose Biolimus A9 because it is so much more lipophilic than the other limus drugs. And so it is more likely to be retained in the tissue. So it's got advantages of potential drug transfer to the vessel wall. It may avoid polymer-related side effects, but doesn't make it safe to shorten DAPT because it's basically a bare metal stent. And this first stent was really a stainless steel stent. Well, in the Leaders Free trial, the first important randomized trial in this space, there were 2,432 patients who were at high bleeding risk, who were randomized to 1 month DAPT treatment with either a bare metal stent, which was then the standard, versus this drug-coated stent, the BioFreedom stent. And the bare metal stent they used was a very similar stainless steel stent. It just didn't have the surface microarchitecture of the drug. And they saw that this stent did definitely act like a drug-eluting stent. It reduced the risk of cardiac, clinically driven TLR at 1 year by about 50%. And in terms of safety, despite 1 month DAPT, it was quite safe. There was no difference in cardiac death. In fact, myocardial infarctions tended to be reduced, probably because of less restenosis. And you'll note there was no difference in stent thrombosis. Although I do want you to note that stent thrombosis was relatively high with both stents. Now keep that 2% number in mind at 1 year. That may be a reflection of the disease complexity, or it may also be a reflection of the stainless steel stent in part. So we'll keep that in mind. Nonetheless, this was a very important study suggesting that you could have a drug-coated stent that was as safe and more effective with 1 month of DAPT in high bleeding risk patients than a bare metal stent. And this has led to a lot of different registry and randomized trials looking at abbreviated DAPT duration. And by that, I'll say mainly 3 months or less. And you can see there were studies with the Synergy stent, with the Xience stent, with the Ultimaster, and with the Onyx stent. And some of these were registries, some of these were randomized. Of course, I tend to put much more stock in randomized data. But we have one randomized trial with Synergy, one randomized trial with Xience, the large-scale master DAPT trial, which is still ongoing, and then one randomized trial with Onyx Resolute. And I'm going to talk about these. So if we quickly look at the senior trial, this was an investigator-sponsored study in 1,200 elderly patients. So that was the high bleeding risk factor that they studied. And these patients had to be greater than or equal to 75 years old. Mean age was 81 years old. And they used 1 month of DAPT in patients with stable ischemic heart disease, but 6 months of DAPT in patients with acute coronary syndromes. And they were randomized 1-to-1 to Synergy versus a bare metal stent. And their primary endpoint was ischemic endpoints. And you could see death, MI, stroke, or ischemia-driven TLR. And not surprisingly, the drug-eluting stent acted like a drug-eluting stent, and it reduced the ischemic endpoint by about 29% with no difference in bleeding. Although again, given that this was a modest sized study and used 6 months of DAPT, it didn't really move the needle that much. The next important study was STOP-DAPT-2. And this was larger. This was a 3,009 patient randomized trial that was performed in Japan. And they used 1 month versus, they tested 1 month versus 12-month DAPT after Xience implantation. And this was in a broad cross-section of patients with limited exclusion criteria. So if you look at who these patients were, in which they were testing 1 month of DAPT after Xience, all the patients got treated with Xience. The median age was 68 years, so moderately old. Normally we can see 64, 65 years old. A quarter of them had troponin positive ACS. 39% had diabetes, so that was high risk. But these were very simple lesions. The median syntax score of these patients was 8. And they also used IVUS or OCT guidance in 98% of the patients, which is really pretty striking. For the 1 month DAPT, they had to do a P2Y12 inhibitor, and it was clopidogrel in 61% of patients and prasugrel in 39%. So they dropped the aspirin at 1 month. So their primary endpoint was a net adverse clinical events endpoint, a composite endpoint of ischemic outcomes or TIMI major or minor bleeding. And you can see at 1 year, while they were powered for non-inferiority, they actually showed superiority. So they had a 3.7% adverse event rate with 12 months of DAPT and a 2.4% adverse event rate with 1 month of DAPT, suggesting 1 month of DAPT was better. But if you break this down into ischemia versus bleeding, which of course you always have to do, their major secondary endpoint was TIMI major or minor bleeding. And here they clearly showed a reduction. And TIMI minor bleeding is a misnomer. This is still large bleeding. And they had a reduction of 1% bleeding. And no matter what scale you use, there was a reduction in important bleeding by about 3/4. But they had no difference whatsoever in the ischemic endpoints. And that's fine. That's what you would like to show. You'd like to show non-inferior for ischemia with short DAPT and reduced bleeding. And they did meet their criteria for non-inferiority. But I wanted you to look at how low these MACE rates are. Incredibly low, about 2% at 1 year. And again, I think that's because the treatments were of very, very simple lesions, mostly stable ischemic heart disease, and with nearly 100% intravascular imaging guidance. So this 1 month DAPT experience doesn't translate, in my opinion, to higher risk patients with true acute coronary syndromes, thrombotic lesions, or undergoing moderately or severely complex PCI. And then finally, we have the Onyx One Global randomized trial. And this was interesting because this wasn't a trial of 1 month DAPT versus 12 months DAPT. This was a trial that said, based on the Leaders Free study, the BioFreedom drug-coated stent, the polymer-free device, established itself as the standard of care for 1 month of DAPT. And so I had the honor to be the study chair of this trial, and we randomized the Resolute Onyx zotarolimab-eluting stent with 1 month of DAPT compared to the BioFreedom drug-coated stent in 1 month of DAPT in about 2,000 patients with high bleeding risk characteristics. And here are the two devices. So BioFreedom, as I mentioned, is not really, the device that was used and tested is not really what I'd call a contemporary DS. It's stainless steel. It's a moderate strut thickness of up to about 120 microns. Everyone's familiar with the Resolute Onyx, cobalt chromium DES with a platinum iridium core, eluting zotarolimab from the BioLinks durable polymer. Most of the sizes are 81 microns, and it comes in 2 to 5 millimeter stent diameters. And these were truly high bleeding risk patients. So about 60% were greater than 75, about 40% were on chronic oral anticoagulants, about 15 or 16% were anemic or received recent transfusions, 15% had renal insufficiency, et cetera, et cetera. The mean age was 74 years, 32% had diabetes, 52% had ACS. And what we allowed was also 1 month DAPT, and then at 1 month, you could drop either the aspirin or the P2Y12 inhibitor. And patients continued on with aspirin in 56% of patients by operator choice, and with P2Y12 inhibitors, usually clopidogrel, in 44% of patients. So if you first look at procedural outcomes, again, just using highly deliverable contemporary stents, there were fewer crossovers required to the other study stent, 0.2% versus 4% with Resolute Onyx. The QCA parameters were initially better with the Onyx device, and so device success was better with Onyx compared to BioFreedom in this relatively unselected patient population. The primary safety endpoint was cardiac death, MI, or stent thrombosis, and this was powered for non-inferiority. And you can see the event rates were very similar. Cardiac death, MI, or stent thrombosis, 17% at 1 year with both devices. And remember, it was 1 month that they went off of DAPT onto single antiplatelet therapy. If you look at the components, there were no differences in MI, cardiac death, or no overall difference in stent thrombosis, although you could see it tended to favor the Resolute Onyx. So looking at myocardial infarction, there was no difference in procedural MIs, but spontaneous myocardial infarctions, the late MIs, the ones that are more prognostically important, were actually reduced with Resolute Onyx compared to BioFreedom. And again, if you look at stent thrombosis, there tended to be less stent thrombosis, primarily within the first 30 days. So if you do a 1 month landmark analysis, and again, this was the time period where DAPT was discontinued, you could see that there were no statistically significant differences within 1 month in either cardiac death, MI, or stent thrombosis, or its 3 components. But after 1 month, there was less myocardial infarction with a p-value of 0.01 with Resolute Onyx. With stent thrombosis, there was no difference in stent thrombosis after 1 month. There tended to be a 50% reduction in stent thrombosis within 30 days with the thinner strut Resolute device while they were both on DAPT, but this was not statistically significant. Finally, if you looked at the powered secondary effectiveness endpoint, again, powered for non-inferiority, target lesion failure at 1 year, there was no difference in target lesion failure. So again, a safety endpoint, similar cardiac death, target vessel MI rates overall, and including within the first 30 days, and clinically driven TLR, which were very low with both stents, tended to be a little bit lower with Resolute Onyx, but both stents did well. And then I guess the question is, well, 1 month DAPT, how did we do on preventing bleeding? Well, these were high bleeding risk patients. And you can see that by the end of the 1 year, 15% had clinically actionable bleeding, and almost 5% had BARC 3 or 5 bleeding. So 3 is major bleeding and 5 is fatal bleeding. And that's despite 1 month DAPT in both groups. And of course, you wouldn't have expected differences, and there weren't differences in this. So we followed up the Onyx 1 randomized trial with what was called the Onyx 1 US Clear study. And we were planning on randomizing, or not randomizing, but enrolling up to an additional 800 patients in the United States and Japan who had similar criteria in the Onyx 1 randomized trial. And this was the regulatory approval study in the United States for this device. And we just needed to meet performance goals of safety and effectiveness, coupling the data with the Resolute outcomes in the international trial, because the international trial did not include US patients. For time, I'm not going to go over the results, but the bottom line is the results were excellent. And if anything, the safety and effectiveness outcomes were similar or maybe even slightly better in the additional US and Japanese patients, most of which were from the US, compared to the Onyx 1 randomized trial. So as a result, the Onyx Resolute drug-eluting stent became the first and to date the only stent to be approved for use in high bleeding risk patients with 1 month of DAPT. And it received this CE mark on June 5th of this year. And the timing of this talk was actually excellent because it was 2 days ago that the US FDA expanded the label for Resolute Onyx and 1 month of dual antiplatelet therapy in patients at high bleeding risk. So if I was going to conclude about DAPT duration and stent selection in high bleeding risk patients, I would tell you that DAPT duration, which may range from 1 month to indefinite use after PCI, must be individualized for each patient based on the relative risk of ischemia versus bleeding. Increased bleeding risk may be more important to patient survival than increased ischemia risk. In patients at high bleeding risk, PCI with contemporary drug-eluting stents and 1 month of DAPT is safe and effective. And in this regard, Resolute Onyx is the first drug-eluting stent to be approved in Europe and the United States for 1 month DAPT use. But additional trials are warranted to determine the optimal DAPT duration in patients both at high bleeding and high ischemic risk, and whether there are differences in safety or effectiveness between contemporary drug-eluting stents in high bleeding risk patients. Again, and that can only be established with head-to-head comparative randomized trials. Thanks very much, Raj.
Thank you very much, Greg. It was fantastic. The timing was impeccable. Given Resolute Onyx approval for 1 month DAPT just a couple of days ago, I guess this is data is so convincing that for patients with high bleeding risk, this is a real contender now for bare metal stents.
What's a bare metal stent?
It's a contender for bare metal, for a short-term DAPT. Yeah.
I was saying, what's a bare metal stent? I must say, we don't use bare metal stents anymore.
Right.
I don't think I can speak to myself, haven't used a bare metal stent in years. So, I mean, the contemporary drug-eluting stents are really safe and effective. And even in patients, there's nothing to suggest the contemporary DS are more thrombogenic than bare metal stents. So, frankly, I'd pull them from the shelf.
Greg, just a couple questions. So where does low-dose rivaroxaban fit into your treatment algorithm now?
Sure.
And then the second one is, are we ever going to get better than 1 month? And what's it going to take to get there?
So are you talking about low-dose rivaroxaban in AFib patients or for secondary prevention?
That.
For secondary prevention. So, that basis is on the COMPASS trial, of course, which showed a reduction in mortality and in particularly great outcomes in patients with peripheral vascular disease. But that was studied a year after PCI in patients who were no longer on DAPT. So we don't have data to use low-dose rivaroxaban early. So while the patient is on DAPT, if you've got a patient without atrial fibrillation that doesn't need a NOAC, I wouldn't yet add a NOAC to DAPT. But if you've got a patient who's at high risk, especially with a lot of a global vasculopathy, and the patient does not have excessive ischemic risk, then it wouldn't be unreasonable to do 1 to 3 months of DAPT. Probably at 3 months, when I drop the DAPT, I usually would drop the aspirin. But in this case, you may not, because of course the COMPASS regimen was low-dose aspirin and low-dose rivaroxaban. And that was the clear winner in that trial. So if I'm going to only, and this is another question, no one's really randomized to dropping the aspirin versus dropping the P2Y12 inhibitor. But I would usually drop the aspirin if I'm going to continue only one drug. My one exception might be if I'm going to use low-dose rivaroxaban, then I would follow the COMPASS regimen and I'd keep the patient on low-dose aspirin and low-dose rivaroxaban. And so again, it's another choice you've got to individualize depending on the patient's global condition. Do they have peripheral vascular disease? What's the risk of ongoing ischemic complications? If you put in 8 stents and they had complex dual bifurcation stenting, et cetera, then I'm going to keep DAPT going on for at least 6 months. And if it was a troponin positive, a non-STEMI or STEMI, then probably for a year. Then at a year, I would probably stop it, and then I might do aspirin and rivaroxaban. So you really have to weigh all the different conditions in every individual patient.
Greg, just a quick question, because you gave this important example right now. Do you feel more comfortable stopping that early on when you do intravascular imaging? How much that, because when you do intravascular imaging, you're sure that you got a good expansion, no malapposition, right? Or of course, it is important also how people react to the information, right? If we look into this older IVUS studies, there was a lot of IVUS utilization, but the reaction to the information was not appropriate all the time, right? So can you make some comments about the utilization of OCT and IVUS, how more comfortable you feel stopping DAPT once you are sure that you got a pristine result?
Sure. So it's a great question. Look, there have been nearly 10 randomized trials of intravascular ultrasound versus angiography-guided DES stent implantation, mostly in moderate to severely complex lesions, and they've all been positive. They've all shown reductions in target lesion revascularization and stent thrombosis. And it's really because of the minimal stent area you achieve and avoiding leaving residual edge disease and dissections. So first of all, I think, while these trials for the most part did not use a lot of intravascular imaging, with the one notable exception being the STOP-DAP2 trial, in which almost every patient got intravascular imaging, I think that these patients should have intravascular imaging. And yes, it would make me feel better to have a short DAP strategy if I know the stent area was large, that I didn't have residual inflow or outflow disease, and that there were no major edge dissections.
Greg, do you have any experience with the Cobra PZF coded stent with a short, extremely short DAP? There is some very nice registry data in Europe with 2 weeks of DAP.
Yeah, no, I have no personal experience with that, and I've not researched it. But the data look good. Specifically in terms of safety, I would expect it to be quite safe to have short DAP. The real question with that device is going to be efficacy in complex lesions, because it's not a drug-eluting device. The polymer may have some anti-proliferative properties, but I'd really like to see a major US randomized trial before I started using that widely.
Yeah, we do use some Cobra stents in our lab. I don't know whether I would say that I was putting, in fact, I have implanted some Cobras in complex lesion, but not a huge experience with it, of course. And we find that it's a pretty good device. But now with, Resolute having a 1 month indication, certainly there will be some shift, I will suspect, in the marketplace. So I think that we're just a little bit over time. Any other comments from Hamel or anyone else? Yeah.
Thanks so much, Raj. This was great.
No, thank you very much. A great discussion, great topics today. Outstanding presentations. Thanks to Dr. Stone, Dr. Geda, Dr. Artizani, for taking your valuable time this morning to be with us. Thanks all the attendees here in US as well as our international attendees. We wish you all a great evening and a good day here in United States. And thanks again. Have a wonderful day. And with this, I'll close this webinar.
Great, Raj. Thank you.